Okay, so that's us all set off there. Thanks everyone for joining the WebEx today. I just wanted to give a quick introduction and welcome you all to the third in a series of 5 webinars that are being run throughout 2016. This month we are welcoming Jim Godin from the College of Southern Nevada in Las Vegas, USA. So Jim is actually the program director for the radiation therapy program, and he's actually been using Vert for quite a while. He had it installed, I think it was 2013, was it, Jim?
2014.
14, there you go. So we've been using it quite heavily since, and I know June's quite a busy time for everyone at the moment, so we're really lucky to have Jim agree to run this session with us today. And it's actually 8 AM local time, so Jim's coming nice and early just to run that with us today, so thanks very much for that. So the webinar is titled Creating a Case Study in Vert, and it's actually going to explain how Jim put together a full patient case history and case study based on one of the sampled DICOM Vert plans. So these are one of the plans that we always provide for new installations and for also all of our customers. So it's going to start with an overview about the need for this material and how Jim actually put this together. And then afterwards we're going to move straight into the lesson with some discussion from myself about how we then developed it into a shareable resource available for all the users. And then, as we discussed before, there'll be time to ask some questions at the end. So make sure you make some notes, and then we can grill Jim later on. So I'm just going to pass control over to Jim. So Jim, you should be able to take control there now. Has that worked?
It did. Could I get full screen? I guess I can.
I think it's on full screen already. Is that?
Well, it's on full screen now, so I'm good.
Great stuff. They should be able to skip at the bottom there.
Got it. Okay, let's see if I can get into this. Good morning, everybody from Las Vegas. As Tom stated, my name's Jim Godin. I'm the Department Chair of Health Sciences and the Program Director for the Radiation Therapy Program here at the College of Southern Nevada. Let's see if I can get my screen working. It's not seem to be working, Tom.
Just try at the bottom. Yeah, there should be an
arrow.
There it is.
There. Got it. I got it. All right. Sorry, everyone. Today's webinar is going to be on the clinical case studies that we created on Vert to better evaluate our students on both the clinical competency aspects of the field as well as the didactic portion of our course. To give a brief background, this came together, well, we talked with Tom about this quite a bit before we put this together. And I want to thank Tom and I want to thank the rest of the Vert team for being so helpful in accommodating us for the construction of this project. When our Vert was finally installed in 2014, we began to look at some of the barriers involved with properly evaluating our senior students to ensure that they had adequate preparation to enter the workforce. In assessing our program, we found that the main concern of clinical training was the passing of the clinical competencies put forth by the American Registry of Radiologic Technology in the detail that we needed them to be completed. As most of the clinics around the world, therapists are busy doing their jobs treating patients, and students usually come second in their education. When our students were ready to comp out on patients, we found that most of the time the students were tested on the major skill sets such as setting up the room, patient positioning, field localization, triangulation, and running of the console. During none of these competencies are the students asked why they were doing certain things. This is a concern to us because the why is really being taken away from many cancer centers as long as the therapists know the sequence of what needs to be done. Last year, there was an article in the American Registry of Radiologic Technology journal that stated that today's therapists are losing touch with the oncology department. It seems that now each section, medical doctors, nurses, dosimetry, physics, etc., is its own component, and the interactions we had years ago are now missing. What has happened to the old school of learning where the students had to know why they were doing certain things and what the consequences of their actions might produce. With all of our new technology, which is outstanding for cancer treatment today, the therapists have lost their skills, allowing computers to do mostly everything for them. And I hate to say it, but many therapists in many centers in the U.S. have become button pushers. Oops. Get used to this in a minute. Being a radiation therapist for over 34 years and educating students for half that time, I realized how technology has improved and how students need to understand still the basics of what radiation therapy is. In other words, old school technology. New technology can reduce a therapist's thinking skills by controlling most of the setups and what is happening, but what is happening to the patient when the beam is on. As long as I'm program director of this program, students will continue to be taught old school technology and ask the why question when performing any skill sets in our laboratory setting. We have continually asked our therapists to expand their questioning during the students' competencies to ask the why question, but with time limitations and my personal fear that many of them don't know why anymore, we had to find an alternate way to ensure our students to let know what they were doing upon graduation and upon entering the workforce. Here at CSN, we have developed a thorough evaluation process as well as a comprehensive clinical binder that outlines everything a student is required to complete prior to graduation. We begin with the Vert Clinical Skills Checklist containing 17 skills, which I'll get to here in just a second, that each student must pass using the Vert system and our variant simulator prior to ever entering the clinical setting. This tells us that the students are prepared to enter the clinical setting with skills above what other students might possess from other local programs. Once the clinical skill sets are completed, the therapist then must check them off and continue them weekly until they are mastered to ensure student comprehension and coordination in working with patients. Students cannot begin to test or comp out on any competencies until the skill sets are mastered and the clinical mentor has signed off on their sheet. We then have the students complete 5 unit exams during their senior year that specifically outline certain skills within the competencies that must be passed prior to graduation. Each unit exam evaluates the students on specific skills in one of the areas in patient care that detailed information about the area that asks those why questions. These unit exams are then tested again in our laboratory setting and our Advanced Radiation Therapy Techniques course prior to graduation. This leads us to today's presentation on the virtual case study. My clinical director and I have decided to create a capstone course to test the students on the continuum of care of the cancer patient. We have designed case studies for all of the major competencies required by the American Registry to be performed in our laboratory setting that might be used multiple ways to ensure learning. Tom will be speaking about this more in a few moments. These case studies do not only test the clinical skills of the students, but examines their critical thinking skills as they progress through the cases. This allows us to evaluate their understanding of why they are doing certain things in cancer care. In our overview, the case studies that we have created today are as follows. We have brain, both primary and metastatic. Thorax, both multiple fields, non-IMRT, and IMRT and/or ARC therapy. Breast, tangents only, tangents with supraclavicular, tangents with supraclav and posterior axillary boost. Special setups, photon or electron boost, prone, IMRT and gating. Abdomen, multi-field non-IMRT and IMRT and/or ARC. Head and neck, multiple fields. Skeletal fields, we have single field spine, multiple field spine, and all extremity. We have our electron fields, both single and abutting fields. And last, we have pelvis, multiple field supine, and multiple field prone. Today, we'll be reviewing our lung cancer case study. And in the development of this case study, we have 8 areas that we assess and have created benchmarks for to test the students on these skills. First, they will be understanding the initial consultation and differential diagnosis, knowledge of medical terminology related to specific cases. We have understanding of all of the lab reports, knowledge of imaging studies related to each of the competencies, evaluation of the stage and grade of the cancer using the AJCC staging form, which is the American Joint Commission on Cancer. 6, we have evaluation of 2D X-ray films and 3D CT MRI scans in determining treatment setups. And we continue to use 2D X-ray films for students' use in our simulator room. 7, recognition of organs at risk and tolerant doses to each site, as well as side effects, when those side effects might occur, and any suggestions to remedy those side effects if possible during the patient education phase. And 8, completion of both hand calculation using TAR techniques and the isocentric field, as well as 3D calculations using our Variant Eclipse planning system. And our students will use the Variant Eclipse here at school to run both a lung plan and their 4-field pelvis plan, which is required by the ARRT. Students pair up in our laboratory session and they work together to answer the questions throughout the case study. Most of what is conducted during the lesson is evaluation of the student's understanding of why things are done. So I'm going to run through the case study as delivered to the students, highlighting 8 areas. Get back to this. Okay, Tom, I'm going to switch this over now.
Yeah, I think you just press escape and then you can go down to the taskbar at the bottom.
Oh, I just hit something. I'm sorry, people. I hit something wrong. Whoops. Now I'm completely mixed up, Tom.
What we wanted to do, Jim? Sorry.
Oh.
Got it?
Yeah, I think I do. Okay. Thank you. In beginning our case studies, we have 8 areas mentioned that we go through to measure the student's comprehension. And I'm going to run through the case study, and I'm going to run through each of those 8 that we have set the benchmarks up for. So with our PowerPoint presentation, the very first thing that we will do is run through the initial diagnosis and the history and physical of the patient. And here we bring up Mr. Robert A., who is a male farmer, who has productive cough for 8 months, loss of appetite for 8 months, and loss of weight up to 25% for 8 months. We try to run through the history and physical, and what I do is I present a number of tests that are negative in order for the students to begin to focus on what the final diagnosis is going to be. You see here that the studies performed were negative, many of them. But what I have outlined in red is much of the medical terminology that the students will have to look up and bring into the class discussion, because many of these can or possibly not be part of the overall diagnosis. The reason that I add negative exams is because we're going to end up with 3 possible diagnoses, but with the information provided through the medical terminology and history, only 1 diagnosis will prevail. And the students must take all of this into account. And at this point, I want to just lead into that some of the case studies that we have developed are not all cancer. We sometimes trick the students out. So in other words, this lung cancer case that we're doing now could actually be a lung abscess and not cancer at all. And the students will have to determine that. In looking at the general information in the examination, I get to test the students on the basics of the vital signs. So when we get into all of the vital signs, we do review what normal is for both pediatric and adult patients, as well as what could go wrong if any or all of the vital signs were abnormal. Under the investigation portion, and this here talks just more about the diminished chest movement, impaired percussion notes, etc. And in the investigation, the students look at lab reports, and we will all discuss the normal ranges of our white blood cells, our red blood cells, our platelets. When those blood counts become too low that we must stop treatment. But in our example here, we just had a report that had an elevation in the hemoglobin and protein in the urine to slightly derail the student and have them look up what could be the cause of these and if they're relevant in the diagnosis. I want the students to understand that when treating cancer patients, other health factors may be present, and therapists must understand if these factors contribute to the overall care of the patient while undergoing radiation therapy. Again, here we continue to do 2D film and review basic anatomy on the film, both normal and abnormal. Here the students examine the lungs, the heart, and other basic anatomy, especially related to bony landmarks. I have placed an arrow with the tumor since it's difficult to see, and we will still use 2D films in our simulator lab so the students are well trained on reading films, setting the magnification factors, using bony anatomy to set clinical fields for emergency patients, as well as for CT sim purposes. Students will isolate the tumor, draw the treatment fields using this GTV, the CTV, irradiated volumes, as well as determining treatment field sizes to set on the machine. We will then verify that with the 3D imaging. This slide here is just a picture of the Vert. This is a picture of our lung cancer, the IMRT, of which Tom was able to take all the plan off, so we were able to have our students plan it on this patient themselves. So the students are then asked the question of what they think the diagnosis could be. And what we do, we give them 3 examples. Here we have pulmonary coax, lung carcinoma, or lung abscess. When dealing with these, the students should have enough information now to realize that, number 1, points against pulmonary coax was there's no high fevers, there's no elevation in temperature, the sputum microscopy was negative, as well as for lung abscess, again, no high-grade fever, no foul-smelling sputum, and the leukocyte counts are normal. So this would lead us to the diagnosis of lung carcinoma. So now we have to speculate that, and the students have to perform examinations to confirm that the diagnosis is that of lung carcinoma. Starting with the CT scan, students will use the Vert system to view scans of the area examined. Again, during this phase, the students review CT anatomy of the major organs. We review contrast and any allergic reactions to contrast media and what to do if a patient has a reverse reaction to contrast. Since we have some centers here locally that use contrast during CT sim, and students must be aware of any possible situations that might occur. The impressions list will guide the students to the next step of the case study. The students are asked to look up and discuss with the class certain findings of how they relate or not relate to the case itself. And through here, we will also list, let me get into it, we have the impressions. The students are asked to look up and discuss the findings that are not related to the case. In one of these, we have Horner syndrome, and that's mentioned because it leads to discussion of paraneoplastic syndromes, which the student learners learn in their oncology course. We move into the biopsy process. Here, the students will discuss again the major biopsies used to perform in order to get any cellular or core anatomy tissue needed for diagnosis. So the students will discuss fine needle aspiration, core biopsy, and invasive dissection of the tumor itself. Each of the student groups can choose one of the 3 different types of biopsies if they choose to do so, and explain each of them in terms of their side effects as well. They use the USG guide, which will define the core needle aspiration or any of the other aspirations. And here, our diagnosis confirmed it was adenocarcinoma of the right upper outer lobe of the lung. Now, at this point, what we do is the students are broken up into 4 groups. Again, there are pairs. We have 8 students in each of these classes. And the students will get up and discuss lung carcinoma in general, and each of them will take a specific pathology to talk about. So they will start off by, of course, the lung cancer itself, the number of cases per year, what are the most major symptoms of lung cancer as well as causes, the 4 different subtypes of squamous, small cell, adeno, and large cell, the most frequent histologic type. Major treatment discussions are made about the basis of lung cancer, and the students at that point will start focusing now on what the lung cancer was that they had actually diagnosed in this setting. So the students will look back at their CT scan, and they will show that the CT showed a 9.2 by 8.1 mass in the upper outer right lung, and staged the cancer using the AJCC staging form that's provided to them in our lab setting. Students determined that the cancer is a stage 3B. Get to that here. This is still running through all of the courses here. Okay. And being a stage 3B cancer, they discuss the treatment options for the patient. The treatment options are researched on their computer since there are multiple treatment options for patients with 3D cancer, and each of them will discuss which type of treatment that they chose. At the end, what we try to do is bring this back to radiation therapy, because that's what we're assessing the students on, and that's what we're training them for. So here, the students have 2 activities. One, they have to set up the treatment field on the conventional simulator using a 2D film, and 2, setting up the same field on the Vert using 3D technology. Tom has removed the plan on the lung case in order for our students to set up the treatment fields directly on the Vert using contours. Students will begin to use static APPA isocentric fields to encompass the tumor. And I always start with the basic fields because the students must then plan the dosimetric calculations by using wire contouring, TAR calculations, and reviewing the isodose curves. Students then move on to the variant eclipse system and to set up the treatment planning, again, doing the contours of all of the organs and organs at risk. They will set up the field beam shapes. They will put in their doses. They will create a DRR as well as a dose volume histogram. Once complete, the students discuss the stochastic and deterministic side effects that the patients might experience during treatment and discuss the educational advice that they would give the patients during that time of treatment, such as nutrition, skin care, side effects, both short-term and long-term. We have many scenarios that we can use during these case studies to review and evaluate students' understanding, their critical thinking skills, patient education, to ensure that each competency that we test them on are completely understood. And Tom will now discuss some of the alternative activities that we use during the case studies. Tom?
Yeah, thanks very much for that, Jim. I'm just going to take control back there, if that's okay.
That's fine, thank you.
Great stuff. So thanks very much again for sharing that, Jim. We'll all probably agree there's quite a lot of work that's gone into that, and it always amazes me every time I see all the work that's gone into it. And I think it's really important to point out the importance of having the radiographer trained in multidisciplinary techniques and going back to the source and understanding different roles and different disciplines that the patient goes through right from day one, really. So I think this is really clear that it's quite an important resource to have something like this. I'm sure other educators may have something similar, and if you don't, then I'm sure you may be considering it. But the idea was, when I saw this and when I spoke to Jim about it, is that I really wanted to make it a resource that we could share with other Vert users. So as you can tell, with there being a lot of kind of staging and pre-radiation therapy treatment steps, there's going to be a smaller niche of Vert in there, but there is still aspects where you can bring it in. So what I wanted to do was to take this presentation and reformat it slightly so it can be used with all of our users. And then as Jim mentioned in the presentation, what we actually did was able to take the DICOM plan and actually change that and alter it so that you can then bring it into your planning system, and then you can actually rework that plan. And that is really the important step and the link that goes between this presentation and using it as a Vert resource. So being able to take the presentation, work through that patient plan, being able to see the CTs, the diagnostic steps, then being able to create your own plan with that, put it into Vert, and then critique that plan with the patient case history and information behind it, really brings it together as a total resource, really. So I wanted to just to kind of show you the steps that I did just to make this available to people. So I'm just going to jump back here to how the session will really look, and we were planning on sending this out to people in support, and we split it into the first section, the first folder, which is this lesson here, which Jim has kindly gone through. This is the first case study section, the PowerPoint, and really you'll see a lot of similarities here between the presentation that Jim's just delivered and the PowerPoint that we send out. I'll just wait for that to load there. So you can see here, again, the same patient name as we go through. I kind of gave it a blank background so you'll be able to use your own presentation slides in that. And really it kind of goes through the same steps and same investigations and that preliminary findings before you then take it through to radiation therapy. Added to that as well a lesson plan that goes with it. So for the educators, they can use this as a basis to be able to understand where to take it next. So again, sorry for the delay on this. It's a little slow over the internet. So you can see here you've got the lesson overview, and then down here we just created a kind of introduction and a lesson breakdown into all of the different slides with a little bit of discussion topics and the resources that are available for each slide if they are. And also I thought this is quite important, bits where you could actually feel free to import your own information and your own educational institute information into that. So that was the first section, and as I've alluded to before, really a lot of that is done pre-Vert. You've got to be careful how you say that. And then if you then move into the second section, which is what Jim was talking about, if you take the 3D plan, you actually now have the CT and structure sets, and this is available in the second section, second folder. So it's kind of really split into two parts with this, and this is where you can get the students to bring in the CT and structure sets into your planning system, and then using that knowledge that you've already got, you can create this plan, and then take it one step further, bring it into Vert, and then having knowledge that they've already learned in the lesson beforehand, critique that plan in Vert. And again, there's a presentation on this, just a kind of bit of an introduction to it. So that's really how you can bring it together to use it in Vert. What I also wanted to talk about was the third section, and this is something that we kind of developed together, and how you can actually use the case study to take it one step further. And we used this with one of the palliative brain sessions, and actually took it as in the patient then had a metastases, and we have that palliative brain patient that you can load into Vert, and we created a lesson plan with it. So you can see, with Jim's help, having that initial start, you can take that patient all the way from initial diagnosis all the way through to his diagnosis scans and his different routes that he would go through on the pathway, then eventually end up with radiation therapy, and then to move on to a brain metastasis. So kind of just an overview of there of how you can really take it and build it, integrate it with Vert to critique, and then take it one step further to look at the maybe palliative plan on the Vert system, and then practice the Vert setup and the simulation of the treatment in Vert. So just a little bit that I wanted to add there, just to Jim's already excellent presentation. Was there anything else that you wanted to speak about there, Jim?
No, I think I'm good. Everything was mentioned, Tom. Thank you.
Yeah, so I think that kind of covers most things. What I want to do now is just take everybody, put everyone's sound back on. So hopefully everyone should be able to speak away. And if people do have any questions, then feel free to jump in and we can hopefully answer those together. Any questions from anybody? So I was going to ask a question actually, Jim. So when you actually get to the stage where you do the treatment planning side of things and then look at the plan afterwards with the students,
Yeah.
do you get each student to create a plan individually?
Yes. Yeah. Well, each group of students, so there's 2 students, and each of them work together on one plan, their own plan. What we try to do is, as the students come and do their plan, they're welcome to choose any dose that they find within any of the protocol studies that are out there. So some students might choose 180 centigrade, other students might choose 225 centigrade. At that point, we like to also bring back the discussion of what will happen to the tumor at a lower dose, what will happen to the tumor at a higher dose, and vice versa, what happens to normal tissue at those doses as well.
And Jim, we just had a question from Janelle from Alberta, and she's just asking, what do you actually do for pediatrics? Is there anything in the pipeline maybe to include that in the future?
Pediatrics is coming. We are working with one of our pediatric doctors here in town, and we don't have anything developed yet because most of our pediatrics go out of state. They go to California for their treatment, but we are in the works of developing that.
Okay, is there any other questions from anybody or any input that you'd like to add there? Bearing in mind that the sound is all back on now for everyone, so you feel free to ask away using your microphones or phones. Nothing, Jim. We've stunned them with the presentation. Yeah, there's another question here from Janelle that I would think we'd just cover. She's just put, I noticed on your skill checklist that there wasn't a specific skill on patient assessment. Is there a reason for that?
Not really, no. The patient assessment, we try to hold off on that on the first semester until they actually get in and actually go in with the physicians to learn a little bit more about the initial consultation and assessment. We talk about it up front, but there's really nothing we can check them off on in the laboratory setting because they're not actually with a patient.
That's interesting. So would you also have something that goes alongside this in terms of working within the clinical setting that would go with this?
The clinical setting, our mentors have come up with some checklists as well, and patient assessment is one of those. This is something that the clinic uses to evaluate the students. both the nursing as well as the initial consultation with the physician rotations.
Okay, Janelle's just put there, thank you, that makes sense. Here we use actors to assess this before going to clinical. So that's a really interesting point there, being able to bring in actors and have that clinical experience using those.
Exactly, and we do use actors. In our Metho class, we actually bring in patients for their final assessment, which is their final examination. Whatever the students choose out of a hat in terms of a cancer or an area, then we go ahead at the end and bring in actors. We've had physicians, we've had physicists, we've had real patients, pediatrics that come in as well for that initial treatment at the end of the course. And it works very well. The students get very upset and nervous, but our clinics like to test them off on actual patients. Since the ARRT requires all of the competencies on actual patients, that's what our clinics like to do.
So I just wanted to point out, with this resource that we've discussed today, the beauty of this is because it's one of the DICOM plans, we can actually make this available to a lot of people, but for educators within their own institute, they'll be able to obviously access their own plan database, and they'll be able to use a range of different plans that they'll have access to that we don't, and they can use that in their institute and build their own. And I'm sure Jim wouldn't mind being a point of reference or a point of contact if anyone had any thoughts on setting up their own case in the future.
Absolutely not. Yep.
I'd be interested to hear from Dean if you're on the line there, actually, because I know you're working clinically. Whether this would be something that you could maybe work with and put together as part of a session for some of the already qualified therapists.
A lot of our education in the UK already covers a great deal of this. But I think as a refresher, for staff that have been qualified a little while and have got into the routine of running in and out of the treatment room and pressing the buttons, it might be something we could look at and adapt, certainly, particularly the investigation and blood levels and that kind of thing. I think there's definitely something we could use here, yeah.
Thanks for that, Dean.
No worries.
Is there any other questions from anyone before we bring this to a close? No? I'll take that as a no. Okay. Well, you can see the email addresses there on screen, and Jim's very kindly offered to be, like I say, a point of contact. So if you have any questions, you can always email Jim, and of course, the team here at Virtual and myself are always available for any questions or queries that you might have. So I think on that note, we'll probably end the meeting there. I'll stop the recording.
Thank you very much, Jim.
Well, thank you for joining. I appreciate it.